One of the QI3s here. I'd like to thank Dr. Rao for her input on the grand rounds and for the input on the patient. Okay, so these are the Zoom slides. No financial disclosures. Okay, so title of my grand rounds is a gray spot. So this patient was a 10-year-old female. She presented to the ED with complaints of a large gray spot in the center part of her vision in her left eye. She doesn't know how long it was, or she didn't know how long it was there for, but ever since she noticed it, it's been there constantly. It was fixed, it didn't really change position. She denied any flashes of light, any floaters, any recent trauma, any recent illness, or any other issues. In terms of her history, she was adopted from Moscow as a toddler, so we don't know any of her family history. When she first came over as part of her medical screening, she was found to have a positive TB spot test in 2012, but per her family, she was treated with 9 months of medication. Otherwise, no significant past histories. So base exam, the right eye was completely normal. The left eye, the visual acuity was decreased. It was 20/80. Otherwise normal. She had an unremarkable anterior segment exam, but then this was her DFE. Can one of the first years describe this for me? John?
So this is a wide field color on this photo of the left eye. The media appears clear. The disc looks, the margins look sharp. The macula, that it looks like a small hyper pigmented spots in the foveal area. In the visualized periphery, there's multiple speckled yellow spots abutting the vessels, and the vessels themselves look they look normal in caliber from what I can see, but it's a little zoomed out. But there's multiple confluent speckled patterns in the periphery.
Good. Do you see anything else? Okay, so that's what you're talking about in the temporal, the speckled spots. Is that what you're talking about over there?
Is there also hemorrhages there, or like? I can't tell if that's just pigment or hemorrhage.
Yeah, so it's a little zoomed out, so it's difficult to tell, but you're right. So she does have numerous like confluent hard exudates, nasal to the macula and within the macula. A little hard to tell because it's a 2D picture, but she did have some thickening of the macula as well. And then here, temporal in the periphery, she has some light bulb aneurysms as well as some telangiectasias. Good job. So what would be on your differential if you saw a patient like this?
Coats disease.
Yeah, anything else? Good. Okay, so yeah, Coats disease would obviously be on top of the differential, but consider things like fever, Eales disease, some other type of chorioretinitis secondary to an infectious or an autoimmune process, especially given her history of a positive TB spot test, or possibly something like sarcoidosis, retinoblastoma, which should be included in differential for any type of leukochoria, or like von Hippel-Lindau. So as part of her workup, when she came to the clinic later that week, we got an OCT. Right eye was completely normal. As you can see, left eye, she has an exudative retinal detachment. We also did a complete autoimmune and infectious workup, particularly because of her positive TB test in the past, but chest x-ray, CBC, syphilis, sarcoid, TB spot test, and toxoplasmosis, all those tests were all negative. So then we got an FA as well. Can somebody describe this for me, maybe one of the second years? Push.
All right, so we have a couple IVFA photos of the left eye. I don't know what the timestamps say, but I'm going to assume they're in sequential order here. But top left, it looks like it's in the AV phase. And temporally, you can see some areas of hyperfluorescence, which are expanding in size as we go forward in time, suggesting that they are leaking. Those little kind of speckled hyperfluorescent areas that are kind of remaining bright. I don't know if that's staining or pooling, but those could be in those aneurysm areas. And yeah, maybe some dropout, but that's largely what I see. The leakage is the most prominent thing.
Yeah, good job. So you're right, they're in like sequential order, and you can see there's leakage, like you said, dropout. You can see the aneurysms as well here temporally. So based on this and based on her clinical picture, we diagnosed the patient with Coates disease. So I'm going to talk a little bit about that. So a bit of background on Coates. There's to date no known genetic or hereditary pattern, but it is more common in males. Represents about 85% of cases. It's typically unilateral in about 95% of cases. It's most commonly diagnosed in children under 8 years of age, but it still can be found occasionally in adults or older children. And this disease is characterized by the presence of retinal telangiectasia. So the vascular dilations or the telangiectasia are primarily found in the temporal part of the retina. And those findings can include ectatic arterioles, microaneurysms, venous dilations, fusiform capillary dilations. So those abnormal blood vessels are leaky, so they leak serum and lipid, and that causes accumulation of exudates and subretinal and interretinal fluid, leads to the exudations that you can see on exam. So clinical findings, because a lot of these cases can be seen in younger children, they can't always vocalize the symptoms that they're having. But if they can, they complain of blurry vision, or they might have been somebody that's noted to have strabismus or leukocoria. And like I said before, any patient with leukocoria, you have to distinguish between other causes of leukocoria and Coates disease, because you want to make sure you're not missing a retinoblastoma. So on DFE, you can see telangiectasias, light bulb aneurysms, which is kind of the buzzword for Coates disease, exudates, and those exudates can be in the periphery, or they can be in the macula as well. If they're in the Henle layer, if there's accumulation in the Henle layer, they can form a stud. Also, patients initially present with an exudative retinal detachment. To diagnose Coates disease, it's primarily based on the clinical findings. As part of the workup, you can get an OCT just to rule out any macular edema or exudative detachments. And then you can get a fluorescein angiogram to confirm the diagnosis and help direct therapy, as we'll talk about a little bit later. On FA, you'll typically find, you can see here, like telangiectatic vessels, areas of dropout, light bulb aneurysms, and then leakage, which you can't really tell too much here, maybe a little bit over there. So staging for Coates disease, there's a few classification systems, but the one that I saw used the most in literature was Shields classification. And it basically stages from 1 to 5. Stage 1 being very mild disease with retinal telangiectasia only. Stage 2 having telangiectasias in combination with exudation. And then further breaking it down whether the exudation is in the fovea or extrafoveal. Stage 3 is exudative retinal detachment. It can be either subtotal or total, and then further divided into whether it's a foveal involving or extrafoveal. Stage 4 is total retinal detachment plus a neovascular glaucoma, and stage 5 is advanced end-stage disease. And then we'll talk about a little bit later about the prognosis of the patient based on these stages. So some of the sequelae or complications of Coates disease, accumulation of all that fluid can lead to a partial or a total exudative retinal detachment, which can cause decreased vision or loss of vision. Very rarely do these patients develop posterior neovascularization, even with the areas of poor blood flow, and even with the fact that some studies have shown that these patients have elevated levels of VEGF. They can show signs of anterior segment ischemia, like NVI, and develop neovascular glaucoma. They can develop cataracts. They can develop AC inflammation, and then very later stages of the disease, you can develop ptysis bulbi. In terms of treatment, for very mild cases with no subretinal fluid or intraretinal fluid, you can opt for observation if you're going to be conservative. The primary therapy nowadays is photocoagulation, and that's directed by the IVFA. So you apply the laser to the areas where you see the telangiectatic vessels in the aneurysms. You use a lower power, longer duration, and a large spot size. And the goal is to prevent the blood vessels from continuing to leak. So, and then you can also apply laser to the areas of non-perfusion and typical scatter photocoagulation settings. This picture is a picture of before and after treatment. So you can see before, there's significant amount of exudation here. And then after treatment, the exudates have resolved. Alternative treatments, cryotherapy is something that was used more historically. It's not too commonly used nowadays because it is a little more destructive, causes a lot of inflammation in the eye, and has a possibility of inducing proliferative vitreoretinopathy. But if it is used, it's used sometimes in a triple freeze thaw fashion to areas of abnormal blood vessels. It can also be used in cases where photocoagulation isn't possible, if the area is too anterior that needs to be treated. Anti-VEGF is still a relatively new therapy. Some of the studies looking at it as an adjuvant therapy. Some of the case reports are promising. For example, one paper that I read had 3 case reports that showed improvement in subretinal fluid using anti-VEGF injections in 3 patients. And they followed it with ablative therapy, and those kids were stable for about a year afterwards. But there's a lack of comparative studies and large-scale studies using anti-VEGF agents. And in general, anti-VEGF isn't very well studied in children, so we don't know what the side effect profile is. Vitreoretinal surgery is a last resort for refractory cases. For example, you use it if there was like exudative detachment that was not allowing laser to take. So, and that would usually involve drainage of the subretinal fluid and applying photocoagulation or ablative therapy. And then as a very last resort, if the patient has developed a blind, painful eye, enucleation. So prognosis, children who present with this disease before the age of 4 tend to have a more aggressive disease course and poorer prognosis than those who are found to have it at a later age. And then Shield, going back to the staging system that I talked about earlier, looked at a series of 124 eyes, and they found that patients had poor visual outcome of 2200 or worse in about 0% of stage 1 disease, 53% of stage 2 disease, 74% of stage 3 disease, and about 100% of patients in stage 4 or 5 disease. And they also found that enucleation was ultimately necessary, very rare, never in stage 1 and 2, 7% of stage 3, 78% of stage 4, and not in stage 5 disease. So going back to our patient, actually today we took her to the OR and we did perform photocoagulation in her left eye. So we're going to plan on follow her up again in another 4 to 6 weeks and see how she's doing at that time. Does anybody have any questions?
This is Dr. Barron. I just have a comment. This was described by George Coates, C-O-A-T-S, in the early 1900s. So it's similar to Fuchs dystrophy. So you can use Coates without the apostrophe. If you're going to put it in, then it goes after the S.
Okay, thank you.
A good presentation, Marlene. It is good. I've had a few patients with Coates when they have. I've tried Avastin on a few of them especially when they have the subretinal fluid involving the fovea and not a lot of exudation, and I've had some good results with it. Once they have exudation or scar over the fovea, there's really no point because that central vision is kind of gone. sometimes I will try the photocoagulation. That doesn't cure fast. I'll go with intravitreal injections. You're right in that we don't use cryo that much anymore, but sometimes if there's a lot of fluid, the laser won't take. So if the laser doesn't take, you kind of have to go with cryo and kind of get it from outside the eye. But it was good presentation.
I have a question, Dr. Reynoso. Oh, sorry, Dr. Eustace.
No, I was going to say I haven't treated a lot of these, but I think cryo does work. It's easy to apply anteriorly, and it really, I haven't had any problems with vitreal, PVR, whatever, in kids that I use it on an ROP. So I think it's not unsafe to use. It's rather easy to use. The other thing is the severity of the disease is directly related to the age of diagnosis. I think it's present from birth, but these kids slip through the cracks, and the kids that have bad disease present with more severe findings at a younger age. And so therefore they're going to have a more severe disease and be more difficult to treat. So that's how I do the age. It's really not age of onset, it's age of discovery. And I think they all should be treated, because if even if they got something in the macula, I think that this exudation continues and continues, and eventually you lose the eye. It becomes icicle and you got to remove it. So I think attempts at treatment is something not necessarily vision saving, it's eyeball saving.
Dr. Eustace, this is Aravinda. Marlene, you did a good job. We did exactly what we would do, but I was wondering, still considering Avastin in this patient in the future. She's 10 years old and she wouldn't let me get near her, but would you consider that?
I have no experience. I've never used that in coach. I don't see why it would work, to be honest with you. I think you gotta make these light bulbs go away. You got to turn out the lights. Right. And so I have no problem with using Avastin in young kids. I'm not worried about any systemic side effects, but I just don't see where it would help in Coast disease. Another thing, you got to treat like hell. You got to go back and probably do it again, and do it again until all the leakage is stopped. And that's been my experience. It takes more than 2, sometimes 3 or 4 treatments to get it all.
What's the spacing you would use? I'm going to see her and reevaluate her again in 4 to 6 weeks, or is that too long? That's my other real question: is when would you retreat? That's
if you look again and you see it looks like there's still exudation, then you still got leaky vessels. So therefore I would go back. I think that time frame is perfectly reasonable.
Yeah, and I've only done a little bit of cryo with you years ago. Do you just go anterior? Obviously you treat the aneurysms, but are you also just treating 360 or just in the FA guided area?
You just ablate the little blood, the light bulbs. The light bulbs in the avascular, in the capillary dropout areas. I don't go, it's usually all temporal. So you just yeah, it's really pretty simple, really, really easy. I think, but it definitely effective. You're not going to cause any problems, I promise you. So, okay.
Hello?
Hey, Aravinda, did you get burns though? Did you get burns with that first treatment?
Yeah, this morning we did it, and we got great burns temporally, where exactly we needed to treat. And so far, I got really nice white burns. We'll see what happens.
I would just keep treating with laser then. I wouldn't go with cryo. If you're getting good burns, I would just kind of keep filling in with cryo. And when you see her in 4 to 6 weeks, if the sub inject with Avastin as well as doing more laser.
So this is I don't want to belabor the point, but Marlene had asked about Avastin. I feel like we throw Avastin at everybody without really knowing. This is not an anti-VEGF mediated disease. I understand that there's some capillary.
Yeah, it stabilizes the blood-retinal barrier. It'll stabilize the blood-retinal barrier. It'll decrease the amount of exudation.
Okay.
Yeah, saying that
because I said I don't know this is a VEGF disease. Okay.
It's
Okay,
not
well,
it's not
thank you.
really the
Appreciate it.
it's not really the VEGF. It's more stabilizing that blood-retinal barrier and trying to decrease the amount of exudation.
I have a question regarding the workup of these patients. Do you usually do a B scan just to make sure that it's not retinoblastoma, given that the presentation can be very similar sometimes, given the telangiectatic vessels, and I don't know, presentations can be similar sometimes and difficult to differentiate. So not sure if you usually get a B scan or not.
B scan, yes. In the old days, I would do CT scan. You're looking for calcifications in retinoblastoma, whereas you don't have that in Coats disease. And where it's confusing is when you got a huge, big exudative detachment in Coats disease, and it looks like you got a subretinal mass. And that's the number one thing that you got to think of. Coats disease, retinoblastoma, those are the two things that are hard to differentiate. And B scan is probably the way to go, looking for calcifications.
Yeah, I agree with Dr. Yusuf. I mean, I wouldn't do it on this patient because you could see everything, and it wasn't like a big amount of exudation that would be masking a mass. You could see that there was no mass there. But when you have like an exudative RD, then you absolutely have to rule it out.
Thank you.
All righty, I guess we're going to move on to the next presentation.
Aaron, can you guys hear me? Let me just share my screen. All righty. Can you guys see my screen okay?
Yes.
Hi everyone, my name is Luke. I'm a first year. We do my grand rounds today. The title of my presentation is A Bloody High Pressure. That's my best British accent you'll hear from me. Special thanks to Dr. Al-Dajali and Dr. Diosran for their help with this presentation. All right, so the reason we were consulted for this patient at UMC was for an elevated IOP. This is a 76-year-old male, arrived at Tunded in the ED via EMS without family. So really not much history to go off of there. But this is what we see when we first see the patient. Does any first year want to help describe this picture for me?
Kaushik?
Yeah, sure. So this is a view of the patient. Looks like the right eye might be through a 28 Doppler lens. So you can see externally, not a great look at the lids, but there's areas of conjunctival injection, possibly subconjunctival heme.
Did we lose him?
Maybe.
So yeah, like he said, there was a significant injection, a little bit of corneal haze there as well, and also really significant for that hyphema. You can see there a little bit of pooling of blood at the bottom there.
Hello?
Oh, he's there.
Yes, I don't know what that was. I'm sorry, did you finish?
Yeah, I mean,
okay.
You can, yeah, we'll just skip ahead.
Okay.
So in a patient with a hyphema, no history, what kind of things should we think about? And anyone can kind of jump in and say something.
Trauma, neovascularization.
Right. Sorry, what was that?
Is that Hog syndrome?
Right, exactly. So traumatic, any sort of blunt trauma can cause hyphema, injury to the iris, pupil sphincter, any of the structure of the angle. Iatrogenic, any sort of anterior chamber procedures, especially in patients with pre-existing irregular vessels in that area. Any NVI, typically from posterior segment ischemia. Anybody with clotting disorders, anybody who's on anticoagulation are more prone to getting these edemas. Any inflammatory infectious cause can result in hyphema, Fuchs heterochromic iridocyclitis. They have like fine bridging vessels at an angle. If you poke at it or do a procedure, you can get some bleeding. I believe it's called Ansler sign. Herpetic uveitis, UGH, can cause hyphema. Intraocular tumors can also cause it. Melanoma, angioma, retinoblastoma, and juvenile xanthogranuloma can also have spontaneous hyphemas. So we were able to get some more history. We called the daughter, and the patient has multiple comorbidities, including diabetes, coronary artery disease, atrial fibrillation, peripheral vascular disease, history of strokes. And so the more history, he had elevated eye pressures since 10 days prior. It appears his baseline vision was LP. Was seen a week prior to coming to UMC by Dr. Budden, received intravitreal anti-VEGF at the time. He was also seen by Dr. Bolton earlier, prior to presentation. There was a plan for a valve placement later that week. However, they're waiting for medical clearance. He was given Diamox, Brimonidine, Timolol, and Dorzolamide drops. Unclear if he's actually taking those. He does stay at a nursing home. However, the family did not apparently agree to that plan and wanted surgery now, which is why he was brought to UMC and brought under our care. So our initial exam, visual acuity was hard to determine mainly because of his alteration. Right eye, notice is central and steady, does not fix and follow. He did not wince to light when we shine. Left eye was at least count fingers. We were kind of able to get him to cooperate in that sense. Definitely could not get him to read from the card. Pupils, right eye had an APD, left eye did not. Pressure-wise, right eye was a sky high of 72, left eye was a normal, and we could not get utility on that. Other things on pen light exam, he did have some conj injection. Otherwise, cornea looks hazy with microcystic edema. Anterior chamber had a 4mm hyphema. And we also, on iris, in the iris exam, we found some neovascularization at around 3 and 11 o'clock, pretty close to the pupillary margin. And additionally, he had a pretty significant cataract really in both eyes. We did dilate him. Right eye, there was really no view. Left eye had a cup to disc of 0.4, some MAs, tortuous vessels, some dot blots in the mid-periphery with peripheral findings as well. Some other things that we did a B scan of the right eye because we couldn't get a view. And it was flat without vidheme, without detachment, no masks that we saw. Gonioscopy, really, we couldn't get it on this patient. Wasn't really cooperative at the time. He was altered, really swatted us away. So as far as the differential goes, coming from that previous list there, really no history of trauma, not iatrogenic, didn't have any clotting disorders, wasn't inflammatory, infectious, didn't really see a tumor on B scan. But we did see some NVI, and we couldn't entirely discount anticoagulation because he was on Pixaban for AFib. So perhaps that might have somewhat contributed to the cause of the bleeding. So does anyone want to jump in and talk about some causes of NVI?
CRVO,
Ocular ischemic
Sure.
syndrome.
OS. I bet right now.
Good. So diabetes, OIS, CRVO, really any vein occlusion, artery occlusion, retinal detachment. Sickle cell is also one of them, retinopathy. Coates disease can also cause NVI, which Marlene just discussed, Eales disease. So most of these are ischemic. About 97% of these are from ischemia. A very small minority are from inflammation, so chronic uveitis and tumors can also cause NVI. But I wanted to shift my talk to talk about neovascular glaucoma, which is what we diagnosed our patient with. So a little bit of epidemiology about, according to a study in Europe, about 3.9% of all glaucomas are NVG. NVG is most commonly caused by diabetic retinopathy, ischemic CRVO, and OIS. These three make up the vast majority of NVG. NVG does occur in over 20% of patients with PDR, and diabetics with NVG in one eye have a 33% chance of getting it in the other eye. So I made a little flow chart of how NVG kind of progresses, although it's definitely not 100%. But you do start with some sort of cause of posterior segment ischemia from things like diabetes, CRVO, OIS, things that we previously mentioned. This results in an imbalance between pro-angiogenic and anti-angiogenic factors. So VEGF tends to increase. That in turn causes vascular proliferation, mainly initially at the pupillary margin, then it kind of progresses radially towards the trabecular metric, although it doesn't have to occur that way. Sometimes you can have NVA without NVI. Then you get a proliferation of a fibrocellular support at the angle, which then reduces aqueous outflow in the eye. And a contractile process then also occurs, resulting in PAS, secondary angle closure, and you can end up with acute painful pressures. So as far as workup goes in the acute setting, ideally you want to get a gonio, although we weren't able to on this patient, to look at the degree of angle closure, look at where the NVA is. You want to dilate to look for etiology. You also want to get a B scan if used for. In the outpatient setting, you'd like to get an IVFA, look for retinal pathology. Carotid ultrasound might also help if you're suspicious for something like LMs. As far as treatment goes, acutely you can give topicals to reduce aqueous production, beta blockers, carbonic anhydrase inhibitors, alpha agonists. Those kind of reduce aqueous production. Perhaps the medicines like latanoprost might not be as effective because those increase outflow, but the outflow tract is blocked anyways, so perhaps those are less effective. You can also give Dimox, PO, IV. You can consider doing anterior chamber paracentesis if you kind of know where the vessels are, so you don't accidentally puncture it and increase the hypema. You can give intravitreal anti-VEGF. You also have to watch for those pressure spikes. PRP is also important to reduce the retinal demand, so to reduce the pro-VEGF factors. And more definitive, you can do glaucoma filtration surgery and tube shunts as well. And really the outcomes are pretty poor for this disease. Poor visual prognosis, mainly from nerve damage from such a high pressure, and also from the pre-existing retinal vascular disease that the patient likely has. So I wanted to share the study that I found about NVG specifically from CRVO. It looked at risk factors for NVG in patients after an acute episode, an acute CRVO. It was a retrospective study looking at 646 charts between 2013 and 2017. They included patients within 90 days of presentation, the so-called 90-day glaucoma. They looked at patients with a prior absence of anterior chamber neovascularization without intravitreal anti-VEGF prior to presentation. And they defined an NVG event as presence of NVI or NVA in a patient with an elevated IOP of greater than 22. So from the results, this is kind of the chart that I took from them. 98 patients met inclusion criteria for them. So some of the factors that they found were most prone to get patients to develop NVG include include having an APD. So patients without an APD, about 10% progressed to NVG, and patients that did have an APD on initial presentation, 29% did progress to NVG. So almost a triple increase there. And also history of hypertension was also significantly related to developing NVG. So in patients without high blood pressure, only around 6% progress. Patients that did have high blood pressure, about 17 ended up progressing to NVG. So again, in total, about 13 out of that 98 developed NVG. There are certain things that they found that were not significantly associated with developing NVG. Gender, BMI, initial systolic, initial blood pressure readings, history of diabetes, which is interesting, and degree of diabetic retinopathy were not significant. And again, history of hypertension, worse visual acuity on initial presentation and initial APD were significant. So they theorized that hypertension causes a change in the retinal arteriolar vasculature to increase risk of neovascularization. But they noted that it was interesting that there was no significant difference in diabetes, and they attributed it to the fact that the study perhaps wasn't powered correctly. And they found that an APD was to be the factor with the greatest hazard ratio for progression to NVG. I think the study kind of highlights the importance of appropriate follow-up for these patients and the importance of gonioscopy to look for NVI, NVA to potentially do PRP or anti-VEGF therapy earlier before the pressures really spike. This is just an interesting study that I found discussing iris thickness in NVG using anterior segment OCT. It was a retrospective study. They included patients with 360-degree angle closure confirmed through gonio. And they measured iris thickness at 1 and 2 millimeters from the pupil edge using anterior segment OCT, both temporally and nasally. Looking at the chart, you can kind of see from left to right, the iris gradually thickens, and from left to right, the disease severity increases. So the controls have an iris thickness of around 0.5 millimeters, gradually decreasing with 360-degree angle closure neovascularization to around 0.3 millimeters. And they also analyzed the effects of PRP and anti-VEGF on iris thickness, although I didn't include the data because they were inconclusive. And I thought this is just interesting because it kind of suggests a new morphologic feature of NVG. Back to our patient. So again, we saw the patient. We gave him topical drops every 5 minutes. His pressure initially was again 72. Dropped to 60 after 6 rounds of post-op and bromonidine. We were able to get Diamox, IV Diamox on board. And his pressure then dropped from 60 to 51. So his pressures were still relatively high after 45 minutes. And because his visual prognosis was poor, he was NLP, we determined his NLP in the affected eye. He was also a poor surgical candidate, and he tested COVID positive. We did decide against any sort of emergent procedure for him. But he did end up getting admitted to the hospital for altered mental status, was discharged on the 14th. He does follow with outside cardiology. We do recommend a carotid duplex ultrasound to look for occlusion for possible OIS. And the patient has follow-up at Healthcare Network with Dr. Al-Dajali on 25th for evaluation for possible comfort surgery. These are my references.
Hi, this is Dr. Al-Dajali. So good job, Luke. So for somebody with NVG, if they're NLP, you don't need to do a tube shunt in them. If they're having pain in their eye, you can, I mean, it's kind of controversial if you put a tube in a blind eye. Some people say not to do it because there's a risk of sympathetic ophthalmia. Some people say to do it. The other option you can do is a CPC. The family was the daughters were very pushy about the surgery. They really brought him in for the purpose of having an emergency tube put in that night because they were upset that his outside ophthalmologist wasn't doing it as an emergency. My understanding is he went to an optometrist's office who then referred him to the ophthalmologist he was seeing, and they didn't really understand the gravity of like how bad off his eye was. They thought that tube shunt would bring back his vision. So once they understood that it wouldn't bring back his vision, they were more okay without having surgery. Initially, they actually wanted to transfer him out of university to another hospital, but I think his COVID positive test kind of prevented that from happening. But if somebody does have vision in their eyes, still you try to do the surgery as quickly as you can to preserve the vision, because a pressure of 70 isn't going to keep the vision very long.
Can you just comment on the efficacy of AC tap and how long it lasts?
So an AC tap is not found to last more than like 24 hours, if that. The reason really to do an AC tap is essentially if you want to do an Avastin and then tap their pressure down so you're not putting in more, bringing their pressure up more. But the AC tap's not going to last more than 24 hours. I mean, some people think it goes up like after 4 hours.
Yeah, so that's important for residents to know that if someone has a very elevated pressure, and let's say you're not in New Orleans or you're one of the remote sites, don't tap someone, get the pressure down, and tell them to come back in a week, because you're treating yourself, not them.
Yeah, that's very true. You're not treating anything. There's even question of post-op day 1 cataract surgeries when they have high pressure, tapping them down. Like some people think the pressure is just going to go up after 4 hours. Like even in those people, it's probably safer just to start drops. But in an NVG, the tap's not going to do anything. And the other thing with NVG is to always gonio them if their cornea is not hazy and you can see a view. If their angle is completely closed, nothing is going to help them other than a tube shunt because they've scarred down their drainage system. If they have some opening, maybe the Avastin can help and reverse it. But usually these people end up needing a tube shunt.
Is it wrong to say in some cases that if you're doing a VEGF injection and then you tap, you can get some egress of some of the material out of the angle, and that may help with some flow issues, especially in sickle patients? I think that can be true. But even just a generic hyphemic, with NVG, getting the anti-VEGF on board, but then also if you do a tap just for localized pressure control acutely, but it may cause some material and facilitate outflow. True or not true?
Are you saying that doing a tap after Avastin is helpful? Is that what you're asking? I'm sorry.
Well, not certainly. It's helpful to decompress the globe, especially if the pressure's already high.
I completely agree. So I actually like it when a patient gets Avastin for NVG before I do the tube shunt. I actually prefer that because then the tube shunt surgery itself isn't going to be as messy, and they actually tend to do better if they get it. And I agree with that. So I have seen NVG reverse. That's why I was saying it's important to gonio, because if they're not completely closed, you can reverse it. And like you said, doing an Avastin and then tapping them, and then it will egress a lot of that blood vessel, and they will reverse the NVG.
Yeah, I guess my point was more semantical. If there's any egress of cellular material from the angle during that decompression of the anterior chamber, which may allow some of the blood cells, if they're forming early clots or just clogging up the drains, that you can maybe get some facilitated outflow by decompressing the anterior chamber a bit, at least acutely. But that just may an old wives' tale that I've learned in the past and held on to a bit.
Old husband's tale.
Yes, Jane. Sorry, old partner's tale.
Exactly. Got to be politically correct in this group, particularly with the female chair.
Yes, ma'am.
All right, so just another thing to keep in mind is sometimes if you can't see the back of the eye, or if you can see it, but there's TRDs or retinal detachments, a chronic retinal detachment can also cause NVI. It may not be a great idea to inject Avastin in the vitreous cavity. Injecting Avastin in the AC also helps reduce the amount of neovascularization, and it'll probably make the glaucoma surgery easier. So you can always inject Avastin in the AC. Just keep in mind when you do this, you inject half the volume. So instead of injecting 0.05, you inject 0.025. And then you do the AC tap first, because if not, you remove the Avastin that you just injected.
Another question, is the chronicity of the NLP matter? If someone comes in kind of acutely NLP, there may be something to save versus if they've been NLP for weeks or months. So, sometimes I've seen a patient who presented as NLP, we did a tap and they restored some vision, even in hand motion or even sometimes better. So I've seen that happen in a couple instances, but if they're NLP for a longer period of time, there's no coming back from that.
Anthony, do you have a cutoff?
That's a vague statement of, I would say, someone comes in, I went blind today, and maybe their baseline was count fingers or hand motion, and, their pressure is acutely high. There could be some compression of acutely that I would say within, 24 to 48 hours, I would probably still treat. If it's much longer than that, I probably would not.
Okay, thanks. All right, y'all. I guess that's it for grand rounds. If nobody else has any comments, good presentations. Good job, guys. Just